that we're talking about is the grasp and fulcrum. So the way that we grasp and fulcrum is that we first explain what each finger is for. So to hold the instrument, you need to have your thumb and index finger placed on the instrument handle. The instrument handle is this right here. So you have your fingers placed there. You hold it with a light C grasp. The instrument needs to be held with the fat pads of both fingers, but it has to be light enough of a grasp that someone can pull the instrument out from your fingers. The function of the thumb and index finger is to hold and roll the instrument. The middle finger, it's going to rest on the shank. This is the shank. So you're going to rest your middle finger here. The function of this finger is to offer stability, feedback, and the feels of vibration. The ring finger, this finger right here, it is placed on an oral structure, so you can place it either on the incisal or occlusal surface of a tooth. And the function of this finger is to be the fulcrum, and its job is to stabilize the hand and allows the arm muscles to work rather than the muscles of the fingers. So you're moving your wrist, you're not using your fingers to move. In this video, you can see that I am using my fulcrum finger with some pressure against the incisor or occlusal surfaces of other teeth to stabilize the instrument. On the posterior teeth, you always instrument from distal surface forward, and you make sure the instrument is not hugging the tooth, but the terminal shank is on the long axis of the tooth. And you can check this by placing the instrument interproximal. To start on the distal line angle with the working end, you point distally and begin instrumenting distally until fully interproximal and can't go any further. The next thing you can do is place the instrument on the distal line angle, but with the working end pointing in the mesial direction, since now you are going to work mesially. In this video, I used the universal curette, the Barnhart 5-6. It is used on all teeth. The working ends are rounded at the toe and have a rounded back. The face of the blade is angled 90 degrees to the terminal shank. It has two lateral cutting edges, which are blades, which are parallel to one another. The correct working end is determined when the instrument is standing up, so the terminal shank is to the long axis of the tooth and not hugging the tooth. Some contraindications and indications would be that this instrument is used for scaling healthy dentition. It can access areas with tight gingiva, and it is more difficult to use a universal curette on deep pocket. The next thing we use are the 3 A's: adaptation, angulation, activation. Adaptation means we place the toe third of the cutting edge or blade against the tooth. Angulation means we close, insert, and open. Close means towards the tooth to avoid any tissue laceration, so the face of the blade is closed at the 0 to 40 degree angle. Insert with the instrument closed against the tooth with the working end moving down into the sulcus or pocket to the JE, which is the junctional epithelium. Open when in the sulcus. The angle of the face of the blade should be opened at 60 to 80 degrees, meaning it is tipped away from the tooth. Then activate. During activation, you make sure you have short overlapping strokes with moderate pressure against the tooth. Make sure the working stroke is away from soft tissue, otherwise you can lacerate the tissue, and needs to be 60 to 80 degrees, the terminal shank angled slightly towards the tooth. The next instrument that I will be demonstrating are the area-specific curettes, the Gracey's 1, 2, 11, 12, and 13, 14. The Gracey 1, 2 is an all anterior teeth canine to canine instrument. The first thing we do is we look for the lower blade. So there's only one blade on each end of the instrument. Same thing for the 11, 12, and the 13, 14. So the 11, 12 is specific for the posterior buccal and mesial surfaces, and the 13-14 is posterior distal surfaces. For this instrument, the face of the blade needs to be 70 degree angle to the terminal shank. It only has one cutting edge and one round toe. To stabilize this instrument, you have to use the fulcrum with pressure against the occlusal or incisal surfaces. So when we start instrumenting, we instrument from the most distal tooth forward. We start at the distal line angle with the working end pointing distally, instrument distally until fully interproximal, and then remove the working end and return it to a distal line angle, but with the working end pointing mesially. Instrument in the mesial direction, fully instrument to the side of the tooth, roll instrument at the mesial line angle to instrument the mesial interproximal. Make sure the instrument is not hugging the tooth, but the terminal shank is on the long axis of the tooth. Once again, you can check this by placing the instrument interproximal. So, just as the universal curette, we also use the 3A's with the Gracey's, which is adaptation, angulation, activation. We use adaptation. We begin to place the toe third of the blade against the tooth. Angulation means we close, insert, open. We close towards the tooth to avoid tissue laceration at the 0 to 40-degree angle. We insert with the instrument close against the tooth with the working end moving down into the sulcus or pocket to the JE, which is the junctional epithelium. Open when in the sulcus. The angle of the face of the blade should be opened at 60 to 80 degrees, meaning it is tipped away from the tooth. To activate, make sure you have short overlapping strokes with moderate pressure against the tooth. Make sure the working stroke is away from the soft tissue, otherwise you can lacerate the tissue. And the working angle needs to be at 70 degrees. The terminal shank angled slightly towards the tooth. To conclude this video, I wanted to talk about a few contraindications for the universal curettes and the Gracey curettes. So we cannot use curettes on green stains because demineralized enamel can lie underneath the green stains. We can't use it on newly erupted teeth, areas of decay, and we can't use it on patients with an active infection. When we are working on the maxilla or the mandible, you palm down in the mandible and up on the maxilla. But on the maxillary anterior, you're palming down as well.